Violence is the last refuge of the incompetent because when they are not able to do anything to justify the things, they use the violence to crush the justice. Now, another classification of the Tinea capitis is it is of three types. That one is grey patch Tinea capitis, which is abbreviated as GPTC. The other is black dot Tinea capitis, which is BDTC, and the third is favus, which I have already discussed. So the first, the grey patch Tinea capitis, GPTC, it is also called scaly type. It begins with an erythematous, scaly, well demarcated patch on the scalp. It spreads centrifugally for few weeks and months. Then it stops spreading and remain there for indefinite period, even for the year, as silent lesion. Lesions are round, scaly plaques which are spreading and expanding progressively. Number two is black dot Tinea capitis BDTC. It begins asymptomatic erythematous scaling patch on scalp which enlarges slowly. Lesions may be single or multiple but diffused and poorly circumscribed. It resembles seborrheic dermatitis. Early lesions are usually overlooked and unnoticed until areas of alopecia become prominent. Lesions are round patches of alopecia with overlying scales. Black dots are at the site of follicular opening. These black dots, which are due to the broken hairs near surface in the dark-haired patients, mostly caused by the trichophyton tonsurens, which causes endothrix type of the scalp infection. M. canis and Trichophyton volicium also responsible sometime. It persists subclinically in scalp, so carriers shedding viable propagules for the decades which are responsible for spreading the infection to the other non-infected people. Favors, I have told you that has already been given in types of the. Now, here one can see the grey patch Tinea capitis, as one can appreciate the grey patch on the scalp, and these are the grey patch Tinea capitis. And here there is a black dot Tinea capitis which is there, as one can appreciate the black dots on the scalp because of these lesions. Now, what are the complications of the Tinea capitis? Chirion is the one of the complication mostly seen. Some people with Tinea capitis develop this severe inflammation. It appears as soft, raised swelling, drain pus, cause thick yellow crusting on the scalp, and the hair falls out or easily pulled out from this lesion. The condition can lead to scarring and the permanent hair loss. So here is the chirion, as one can see the permanent hair loss and the other characteristic of the lesion. Now, the diagnosis of Tinea capitis, it consists of 6 parameters. Number 1 is history and a clinical examination. Number 2, Wood's light examination. Number 3, wet mount preparation. Number 4, KOH, potassium hydroxide preparation. Number 5 is fungus culture. And number 6 is skin biopsy. First, the history and clinical examination. One should note symptoms, clinical examination of the child with scaling, hair loss, or erythema of the scalp. In microsporum canis infection, trichoscopy will show characteristic small comma hairs. Number two is wood light examination. A wood lamp is a light that uses long wave ultraviolet light of 365 nanometer. When an area of the scalp that is infected with Tinea capitis is viewed, fungus will glow. These infected hairs fluoresce and gives a greenish yellow fluorescence, means positive wood light test. It is seen in Microsporum canis, Microsporum gypsum, Trichophyton equinum, and Trichophyton verrucosum. Infection caused by the Trichophyton tonsurens and Trichophyton verlicum, which are anthropophilic, do not flourish, that gave negative wood light examination test, and lack of fluorescence does not mean it is not microsporum, as I have already told you. So here is a wood light lamp, and that is the wood lamp with fluorescence. One can see the fluorescence of this lesion under the wood light, and similarly the fluorescence of this lesion under the wood light. Now, third is wet mount preparation, microscopic examination of the slides of the skin scraping, nail scraping, and the hair is seen under the light microscopy to see the fungal component. Next is KOH preparation, potassium hydroxide preparation. We place the tissue or the sample on a glass slide, add 10 to 20% potassium hydroxide as it dissolves keratin to help clear the tissue from the keratin embedment. Gentle heating also dissolves the keratin. Now add the cover slip and place the slide under the light microscope and examine. One can see the fungal spore and the hyphae. Here in potassium hydroxide preparation, 15% cases give false negative results. So we have to trust for these fungal lesions by identifying the doing fungal culture. So here how to prepare a wet mount, right? We put a drop of water on the glass slide, and put the sample in that, and then we are able to see this lesion, and this is endothrix. One can see the spores inside the shaft of the hair, so that is the wet mount preparation. And here in case of potassium hydroxide preparation, that is the positive, one can see the hyphae clearly, as one can appreciate here, because the keratin has been dissolved by the potassium hydroxide, and one can see clearly the hyphae after that. The next parameter is fungus culture. It is a gold standard culture from the infected tissue only. Hair, scalp, scraping with blade or toothbrush, hairbrush, or the moistened cotton swab method is used to take the sample. Now roll the swab over all quadrants of the scalp to take the sample, inoculate on the dermatophyte test medium. As the fungus grows slowly, culture results are positive after 10 to 14 days on the seborrheic dextrose agar. It provides identification of the causative organism by examining morphology of the fungus. In non-fluorescent Tinea capitis, Trichophyton tonsurens and Trichophyton verlicum do select spotty alopecia and scaly lesions. Hair from the suspicion area is taken and culture them regularly. So here one can see the culture, and after culture we do take the sample from here and do the direct microscopy, and on microscopy we are able to see the different fungus and we can identify accordingly, and that is the way we can do the macroscopy of the culture plates, and we can identify the culture plates also having the different colors, and then doing the microscopy we can definitely see the which species is there. Now the last is skin biopsy. It is done if the other ways fail, all the wet mounting and potassium hydroxide and the other culture that is not giving the positive result. That is to see the characteristic histology changes. Skin biopsy shows characteristic histopathological feature of the Tinea capitis. Scalp biopsy histopathology shows fungi distributed in the stratum corneum, hyphae extending down to the hair follicle placed on the surface of the hair shaft. Now here one can see the scalp ring form, as one can see that is the hair, and that is the one can see the fungal spores. These are outside the hair, and that is the ectothrix, which is just, and then we can also have some of the spores in the nearby area of the skin also. Now, what are the differential diagnoses of the Tinea capitis? As it is difficult to distinguish from the other skin diseases that cause scaling, the diagnosis is done by positive microscopic examination and the culture of the epilated hair. So, among the differential diagnoses, here comes the alopecia areata, atopic dermatitis, xerosis, folliculitis, seborrheic dermatitis, psoriasis, and systemic lupus erythematosus, which is SLE. So here one can see the alopecia areata that also gives this kind of the picture, and xerosis of the scalp that is also giving the misdiagnosis, atopic dermatitis of the scalp that is also giving the near picture, and scalp folliculitis that also mimic the Tinea capitis. Then seborrheic dermatitis, as one can see, the psoriasis of the scalp, and then SLE of the scalp, that is all in the differential diagnosis of Tinea capitis. It is said that in knowledge is, there is sea of knowledge everywhere, in the books, in the textbooks, in the internet, and everywhere. But the role of teacher cannot be negated, because which one is going to learn, the student going to learn in few hours, few days, and the teacher is just going to put it in their brain in few seconds and few minutes. So respect your teacher, and there is no substitute of experience, and there is no substitute of teacher. Now, coming to the treatment of Tinea capitis, ectothrix infections resolve on their own because the spores just get off. But endothrix infection may become chronic and may continue into the adulthood. Some consider oral ketoconazole first choice for endothrix infection by Trichophyton tonsurans. Treatment mainly is of three types: general measures, number 2 topical treatment, and number 3 oral or systemic treatment. First, the general measures. Take necessary sanitation measures to prevent spread and recurrence of the infection. Fomites and the asymptomatic carriers cause the spread and reinfection, So treat them so that chances of infection can be minimized. Treat all the patient, all family members, including the adults, and sterilize the home environment as part of general measures. Careful hygiene of the combs, brushes, headgear, and head accessories should not be shared, and discard the fomites. If zoophilic pathogen like Microsporum canis is isolated, identify and treat the infected animal from where one can get the infection. The second part of the treatment is topical treatment. No topical treatment or therapy alone is as effective as oral glycopholmin. Different topical application impede and stop shedding of the viable fungi from the infected scalp, but oral glycopholmin is the gold standard. Now, continuing topical treatment, these just minimize spread of the infection and to stabilize infectious particles. It includes selenium sulfide 1 to 2.5% shampoo, ketoconazole 2% shampoo, and econazole nitrate to decrease inoculum shedding. Sometimes cyclopirox shampoo is used. Used topical sporocidal shampoo several times a week, and it is advised that vigorous daily scrub of the scalp also help remove of the infectious debris. One have to keep all these shampoo, the contact of the shampoo with the lien for at least 5 to 10 minutes so that the drug can affect properly with the fungus. Best results are topical therapies to affected area plus glycopholmin orally, that is about 88 to 100% results if we combine the glycopholmin orally and the topical treatment, any of these. So here one can see selenium sulfide topical 2.5% lotion, then ketoconazole shampoo 2% lotion, econazole nitrate cream, and cyclopirox shampoo 1%. These are all the topical. Now, coming to the third option, that is the oral systemic treatment. It consists of oral antifungal agent. Glycopholmin is the mostly used drug and very effective also. Other are terbinafine, itraconazole, and fluconazole, shorter treatment duration, but the problem with the glycopholmin is that the treatment is of long duration. The treatment of choice is oral glycopholmin, a secondary metabolite of fungus Penicillium glycopholmin. A fungostatic means it just inhibits the growth and the reproduction of the fungi as compared to fungicidal, which kills the fungus. So it is a fungostatic affect cytoplasmic microtubular system of the fungi, so interfere with the mitotic spindle and no more reproduction is there and the growth is inhibited. Dose is 10 to 20 milligram per kg per day for 6 to 8 weeks, or 20 to 25 milligram per kg per day of micro-size formulation in single or divided dose. It is an improved form of the glycopholmin. So here one can see the glycopholmin tablet 250 milligram and 125 milligram, and here one can see the glycopholmin tablet, and there is glycopholmin syrup which can be used for the kids. And here is the advanced form of the glycopholmin, which is called ultra micro-size glycopholmin tablet. Now, continuing oral treatment, the ultra micro-size product has enhanced absorption available 125 to 330 milligram tablet Terbinafine, very effective in trichophyton tonsillensis infection, approved for the use by the children aged 4 years and older. Antifungal granules are sprinkled on a child's food to treat the infection. If there is very difficulty for the child to take the syrup, it is just you sprinkle the granules on the food, and that is easily palatable by the kid. It is less effective in infection by the Microsporum canis. Topical and oral antibiotics are used to treat the secondary infection, and prednisone to diminish the severe chirion. Topical and systemic steroid plus antihistamine are also effective to relieve the pruritus and to set aside the inflammation and to kill the fungus all at one time. So here one can see terbinafine 250 milligram tablet, that is itraconazole capsule, available at 200 milligram, also available as 100 milligram. Similarly, terbinafine 500 is also available. Fluconazole capsule, mostly 150 milligram, but 50 milligram is also available. And similarly, ketoconazole tablet is available in 200 milligram. Now, after the treatment, the prevention is very important. Routine scalp examination of the young school children regularly to avoid the outbreaks, and keep the scalp clean, wash with a medicated shampoo containing ketoconazole or selenium sulfide, as I have already told you. Good hygiene and avoidance of the sharing headgear, combs, and the hair brushes, and anything which is responsible and can spread the problem should not be shared with the person who is a doubtful infected person. Soak in bleach all these things which I have told you for 3 days in a row. Barber shop instrument should be disinfected after use, and all infected children, adults, or pets are treated to prevent transmission of infections. Wash the towels with the soap and dry in heat so that fungus can be killed. Now, last, the prognosis. It's hard to get rid of the ringworm. Problem may come back after it is treated. It may get better on its own after puberty. And that is the end of the lecture. I have tried to give the maximum about the topic, and I hope you will like it. And if you like it, please subscribe and share it with the other so that the other can get benefit.